A very warm welcome to everyone out there for tonight's ESG webinar. This is an event that is sponsored by Medtronic, and we will talk about innovations in hemostatic powders. My name is Timo Rath, and I'm very happy and honored to co-host this webinar with Professor Gabriel Rahmi from the Georges Pompidou Hospital in Paris.
Hello.
And I'm very sure that the majority of you know Professor Rahmi in terms of his advanced endoscopic resections, advanced mucosal resections, advanced or endoscopic submucosal dissections. And during this webinar, the two of us will try to follow a dual intent. First, we want to discuss with you how we can use Next powder as a new hemostatic powder for treating our GI bleeding with very high effectiveness. And secondly, we also want to show you and share our experience how we can prevent post-resection bleeding. Before we actually go into the topic, there's one note about housekeeping. This is the fourth consecutive year that the ESG offers the opportunity to view high-quality presentations from experts in the field, different topics. And we would like to encourage you really to interact with us. Please use the Q&A function to answer questions, everything that goes through your mind to really have a viable discussion and an interactive webinar. And secondly, before we actually start, we have a poll for you. And during this poll, we want to kind of cover basics aspects for GI bleeding and how we manage GI bleeding. And this poll is based on the current 2021 ESGE guidelines. And the very first question that we have for you refers to upper GI bleeding. So in case of upper GI bleeding, when does the ESGE guideline recommend to perform upper GI endoscopy? Answer one, is it urgent endoscopy defined within the first 12 hours? Answer two, is it early endoscopy that is recommended, so within the first 24 hours? Or answer three, is it late endoscopy within the first 48 hours that is recommended by the actual ESGE guidelines? And in case you don't have the actual statement in your mind, you might remember yourself of two studies that came out just recently, 2020 and 21, published in the New England Journal and in Gut, so high-ranked publication that exactly addressed this issue. That was kind of in favor for us endoscopies, as they show that we might not need to get up during the night in any case, but have a little bit more time. So this is a hint, and please vote now. Maybe we also already see, while reading out the questions, the results of this very first vote. It's coming up in a second. Oh yeah, so we have a mixture here. Answer one, urgent endoscopy, 38% of participants. Answer two, early within the first 24 hours, 62%. So let's look at the correct answer, what ESGE recommends. We do have the results here. As you can see, ESGE recommends that following hemodynamic resuscitation early within the first 24 hours, upper GI endoscopy should be performed. So good news for us endoscopists, not super urgent within the first 12 hours, but we have a little bit more time, 24 hours. And actually, if we look at statement 4, the ESG does not recommend urgent upper GI endoscopy within the first 12 hours, since as compared to early endoscopy, patient outcomes are not improved. And actually, if you look at single studies on this aspect, there are also studies that the outcome is worse with urgent endoscopy within the first 12 hours. So that was question number 2. Let's go back to question, move on with question 2. How do you treat a patient with actively bleeding ulcers, FOREST 1A or 1B? Answer 1, injection of epinephrine as the sole means. Answer 2, application of an endoscopic clip as a sole means. Or answer 3, combination therapy, injection plus a second hemostatic modality, contact, thermal, or mechanical. So please vote. And I'm very sure that this is a scenario that all participants, all you out there know fairly well. It's almost daily business for us endoscopists. So that should be an easy question for the majority of us, even without looking at the guidelines, but maybe we can have the results. The results come up here. Oh, yeah, this is more than 90%. Answer 3, combination therapy, injection, plus a second hemostatic modality. Let's look at the correct answer. This can be done rather quick. Yeah, so statement 5 in this 2021 position statement of the ESGE. For patients with actively bleeding ulcers, first 1A, 1B combination therapy, as discussed, with strong recommendation, high quality evidence is the way to go. So question 3, what does ESGE suggest in patients with persistent bleeding refractory to standard hemostasis modalities? Now, this is a little bit tricky. I'll tell you why. So answer 1, topical powder. Answer 2, injection of fibrin glue. Answer 3, cap-mounted clip. This is actually a poll where you can choose 2 answers, and 2 might be correct, actually. So this is the hint I'm giving you at the moment. But I'm pretty sure that the majority of you also are very much aware what alternatives we have in terms of treatment when bleeding is refractory. So maybe we can see the results already. Yeah, that is very good. So topical powder, answer 1, 66%. Answer 2, fibrin glue injection, 22%. Cap-mounted clip, 66%. Let's look at the correct answer. You'll see that on this slide here, statement 7 in the actual ESGE position statement. With persistent bleeding refractory to standard hemostasis modalities, the use of a topical hemostatic spray powder or cap-mounted clip or over-the-scope clip, however you like to call them, should be considered. So answer 1 and answer 3 are correct. And with this, we're directly into the topic. This is the bridge to what we discussed during the next 45 minutes. We will talk about hemostatic powders. During the first part of this webinar, we'll talk about how we can use a new device called NextPowder for treating active GI bleeding. And I'll show you an experience that we obtained in our department on the basis of pre-recorded cases. Before we do that, just to give you a broad overview, what kind of tools do we have actually for endoscopic hemostasis? Well, we have a variety. We have thermal devices divided into the subcategory contact or non-contact devices, contact devices, heater probes that are still frequently used, or coagulation forceps, non-contact devices such as argon plasma coagulation that is utilized by the majority of endoscopy centers. Apart from thermal devices, we have injection devices. Everyone knows it, and it's used on a daily basis. Epinephrine injection, as we already had during the poll. And then finally, we have mechanical device, sometimes also referred to definitive devices. Mechanical devices with the subcategories through the scope clips, TTS, or over the scope clips, cap-mounted clips. And finally, also, we have endoscopic suturing devices, although the later are certainly not as far distributed as TTS clips or OTS clips. And then finally, as kind of the new agent class, we have topical or touch-free endoscopic powders. And here we have a new kid on the block, which is called NextPowder. And NextPowder is really the device that we want to talk about within the next minutes. So what is NextPowder and how do we use it? You'll see that on this slide here, NextPowder, first of all, from the technical components, is a biodegradable polymer. It consists of oxidized dextran that is linked to a polylysine amino acid chain. And what happens when you spray it onto the mucosa or the bleeding site, a cross-linking occurs that forms into an adhesive gel. And before we look at that, first let's review how it is applied. And the application device or spray body, you see that here in the upper left image. And if we take a closer look at this spray body or the application device, it consists of 3 important components. First, we have the spray body that is attached to a spray catheter, 7.5 French. And finally, on the top mounted, we have the actual vial containing the NextPowder. So the way you want to use NextPowder, and this is really important, is the following. When you open the box and take the NextPowder, the application device, the spray body out of the package, you want to make sure that the valve is actually closed here in this down position. And ensuring that, you can release here the battery protector and then switch on the device with the power button. And when you do that, you have constant airflow through the spraying catheter. So with this airflow through the catheter, but the valve closed, you want to insert the catheter through the working channel. That way you ensure that the catheter, which is flowed with air constantly, and the working channel remain dry. And when you then reach the target tissue and have the catheter advance 2 to 3 centimeters out of your distal scope end, then you want to slowly open the valve to release the powder. That way you prevent actually clotting of the active substance of next powder in your working channel or in the catheter. And what happens when next powder comes into contact with blood or water is, you see that on the small video here in the upper right quarter, it instantaneously turns into a gel formation. You see that here. And this gel has a blue color and easily withstands gravity. As you can see here, we turn the Petri dish upside down, but the powder or the gel remains sticky to the Petri dish. So when we use next powder, it's actually a three-step process that we're looking at. First, the powder, when in contact with blood or water, forms into a highly adhesive gel. This adhesive gel then provides a mechanical barrier. In a way, it's kind of an endoscopic seal or a band-aid, if you wish. And we know that from the very first studies, this gel is kind of long-lasting, longly attached to the mucosa. It is degraded within 1 to 3 days. And the studies have shown that even after 3 days, in 40% of the patients, you still see the adhesive gel attached to the mucosa. So it's no secret that there are a variety of endoscopic or hemostatic powders out there. And having said so, I think it's important to briefly remind us what the physical or technical properties of these devices are. So with next powder, I think one of the important things is that we use room air as an air source. And with this room air, we have a low pressure application. And this low pressure application leads to the fact that we have very low scattering of the powder while spraying it onto the mucosa, and thereby have maintained endoscopic view throughout the procedure. If you look at other substances labeled with substance A, but I'm sure you all know what it is hemospray, that is expelled with CO2. That is a high pressure application. High pressure application means we have a lot of scattering when we apply the powder, and therefore difficulties in maintaining our view. And finally, we have a third substance, which is called Endoclon, that uses air, room air still as an air source. However, if you look at the adhesion forces of those three agents, next powder, hemospray, and Endoclod, you can see that the adhesion force is remarkably higher with next powder as compared to hemospray or Endoclod. And this is because it forms into a highly adhesive gel by cross-linking of the dextran with polylysin when it gets in contact with blood or water. And this highly adhesive capabilities are shown in this very telling experiment. You see here, next powder and hemospray were brought into a Petri dish, and those Petri dishes were shaped in an acidic environment for 1 hour. And as you can see here, next powder after 1 hour shaking is still in place, whereas the hemospray after 1 hour shaking acidic environment is virtually gone. But of course, we don't want to talk about experiments so much. We want to talk about experience cases and how we apply it. So what you see here, what I brought here for you is a video of a 80-year-old one that presented earlier this year to our emergency room. He reported of stereo since 3 days, and correspondingly, we observed an anemia on admission. So we then performed endoscopy within 24 hours. This is what we just discussed during the poll. And we're looking now at the small curvature of the stomach. And I think you can easily recognize we're looking at kind of fragile tissue here. So this is the endoscopic view onto an adenocarcinoma of the stomach. And as I think you can also easily appreciate that we have a Forest 1B bleeding here. So what did we do? Because it's fragile tissue, you don't want to inject so much with a needle because this leads to further bleeding sites. We sprayed next powder onto this site. And as you can see here, and this is the first lesson from this video, you maintain endoscopic view throughout the procedure. And also, as you can see here from the second video, you're able also not only to maintain view, but also to cover a large surface with Next powder. And as you can then see on the third video, while spraying Next powder on the mucosa at the borders of the lesion, we can already see how gel formation occurs, indicated here by the blue color. So this was a very successful endoscopic hemostasis. We never heard back of that patient. So, and to me, in this case, I chose Next powder because it's fragile, vulnerable tissue. We all know that clips don't hold in this vulnerable, fragile mucosa. Injection is also something that leads to additional needle holes and can actually induce further bleeding sites. Second case here is a 76-year-old female in her history, metastatic ovarian cancer. She presented to our department during last summer with recurrent hematemesis. She was likewise anemic on admission, but also had a positive shock index, as indicated by hypotension and tachycardia. And what you see here on those videos is when we go through the pylorus, we look at a large ulcerated surface in the duodenal bulb. And I think, as you can appreciate from those videos, it's a semicircumferential peptic ulcer, or even it's a little bit more than the half of the circumference of the duodenal bulb. So what did we do? The answer is clear. I also used Next powder in this patient because it's a large ulcerated surface, fragile tissue. And what you can see from this video, even though it's a large surface, look at the right video, actually the whole duodenal bulb is covered with one vial of Next powder. So you can use it for very large bleeding sites, for prevention of bleeding or resection site, as we'll hear during the second talk. So we've talked about upper GI tract application of Next powder in the upper GI tract. What do we know about lower GI tract on the basis of pre-recorded cases? Here I brought a case of a 73-year-old female, and she had a vulva cancer with a history of pelvic radiation. She presented to our department with rectal bleeding for 2 days. She was also anemic on admission and also had a positive shock index. So those are the white light images from rectum and sigmoid. As you can see here, we have diffuse bleeding and sigmoid. We did extensive washing. What did we see? Well, this was, as you all already anticipate, a classic case of radiation proctitis. And our initial approach was to APC those lesions. However, after performing APC quite extensively, we saw persistent bleeding here from the right-sided lesion, leading to a persistent forest 1B bleeding. And finally, we achieved, in this case, bleeding control with Next powder, also due to the fact that it is a non-touch delivery or application of the powder. And the fourth case very much resembles what we just discussed. 59-year-old female, history of rectal cancer, also in her history radiation therapy. She had, because of her rectal cancer, also a history of colostomy, and also presented with recurrent rectal bleeding. Now, what we performed here is lower GI endoscopy through the site of colostomy. So on the very left image, we kind of look onto the anal canal, because we scope the patient here through the colostomy. And what you see here is, again, the prototype picture of radiation proctitis. And as you can already appreciate from those still images, this is very vulnerable mucosa. And this is also why I decided here to cover the whole rectum with Next powder. And I think you can appreciate what we just discussed and learned about Next powder. We can cover circumferential lesions while at the same time maintaining endoscopic view. And thirdly, we don't get into contact with mucosa. And apart from cancer bleeding that we saw in the very first case, this is another indication where I use Next powder frequently in order not to stress the mucosa or put more harm to the mucosa, as with mechanical devices or injection therapy. So, but apart from case studies, what does literature tell us about hemostatic abilities derived from Next powder? Well, the first studies came out in 2019, and one of those publications included 56 patients with GI bleeding. The majority were post-interventional, post-resection bleeding. And in this study, we saw an overall success of immediate hemostasis in 96% of cases. So 56 patients included in 55 successful immediate hemostasis was achieved with Next powder. And if you look at day 7 rebleeding rate, remarkably, hemostatic abilities remain stable, only 3.7% rebleeding rate after 7 days. And another remarkable thing about this study to me is there were a lot of 1B bleeding, first 1B bleeding activities in there. So really active bleeding, and as shown by this study, effective control with Next powder. Followed by that, there came another study, a little bit smaller, 17 patients. And here, successful initial hemostasis was achieved in 16 patients. Well, you might say, well, this is a very small number, but those 17 patients, those were refractory bleedings to prior conventional therapy. Conventional therapy, those were treated with thermal devices or thermal devices in combination with hemoclipping. And those refractory patients, those were then treated with Next powder. And remarkably here, in 94% of cases, we had effective and successful hemostasis with Next powder. And this is also something that we can observe in our cohort, in our experience here, when we do an interim analysis of all those patients that we used Next powder, and we have a success of immediate hemostasis in 98% of cases. So during the table where we discussed physical properties, I already mentioned other devices to you, Hemospray and Endoclod. So in the past, we've also analyzed the hemostatic efficacy of Hemospray and Endoclod. And as you can see here in our cohort that we published in 2019, we observed a short-term success defined as successful hemostasis within the first 72 hours of only 82%. Talking about Hemospray especially, I told you when reviewing the physical properties, it's expelled with high pressure, CO2. Remarkably, in this cohort of 102 patients treated with Hemospray, we had 2 intestinal perforations, one with a very large ulceration, the other one with very fragile tissue due to an adenocarcinoma of the stomach. And here, high pressure application actually resulted in such a high pressure that we had intestinal perforation. And if you look at other studies with Hemospray especially, you will find cases of intestinal perforation. And here, just to close the loop to the technical properties that we initially review, one of the beauties of Next powder is certainly to me the low pressure application with the room air, where you can maintain endoscopic view, but also don't endanger intestinal perforation. So with this, I would like to come to the following conclusion. So Next powder, as discussed during the last 15 minutes, provides a mechanical barrier to bleeding sites, and that occurs by gelation after contact with either blood or water. And to me, it has a superior application for the various reasons that we just discussed, allowing for coverage of large surfaces while at the same time maintaining endoscopic view with reduced or maybe even zero catheter clotting that occurs with Next powder, especially if you pay attention to what we initially discussed, how to use it. Turn on the spray body with the valve closed so that you ensure that the catheter has a constant airflow, and with constant airflow, you insert the catheter through the working channel. And only after you reach your target site, you open the valve for controlled powder release. And with these properties, Next powder enables a highly effective touch-free hemostasis and prophylaxis of rebleeding. Thank you very much.
Thank you very much, Professor Rath. It's a great lecture, an excellent presentation. We have many questions. Then I am quite happy. Thank you from the audience. And the first one, probably it's about the mechanism of the powder and how could we use the powder if we don't have active bleeding, for example, an ulcer for S2A.
Yep.
For
Yep.
What is
Yep.
your opinion?
That's a great question. And actually, this is actually the point and one of the beauties. We need only contact with blood or water, contact with fluid. This is key here. And of course, mucous membranes, the mucosa within the GI tract has a tiny amount of fluid on top. So this is why you can use it not only for bleeding, but also for prevention of post-resection bleeding. And it's in case you don't see gel formation during the procedure when you apply it, you can also actually through the working channel flush water in onto the site that you just sprayed. And when you then put external water onto your resection site covered with next powder, you see that this kind of catalyzes gel formation. So yeah, with blood, water, fluid, it works.
Yeah, then water is quite important when we want to make gelation. We can add some water if
right. So it's hydrophilic. Yeah, this is
hydrophilic. You're right. And another question, Professor Rath, about the duodenal ulcer you treated. What about the question of a second look endoscopy?
Yeah.
Do you plan to make a?
Yeah, that's a good question. I have to admit, we don't perform second look endoscopy on a regular basis. And also, if you look at the studies, they're not kind of very consistently done. So our approach is here to have her monitored, vital signs, plus frequent checks of the red of the hemoglobin levels. And if we see a drop more than 2 grams of hemoglobin drop, we perform another endoscopy. But second look endoscopy is in most cases not part of our routine care.
Yes, I totally agree with that, and we make the same monitoring after the treatment. What about? I think we can have one other questions. What about the risk of gelling or clotting of the tip of the catheter of the endoscope? Do we have some worry about the endoscope? Or no?
Yeah. I also want to be very honest with you. I had it once. That was my own fault. So there are things you need to pay attention to, as we just discussed. Make sure that you have airflow without powder when inserting. Another thing I didn't mention yet: don't aspirate while spraying.
Okay.
Because that leads, of course, to the fact that you also have powder in your working channel. And in one situation where kind of high bleeding activity in the middle of the night while I was in service occurred, and I accidentally had a little bit of suction on my scope, and that led to a catheter clotting. But otherwise, and as I've shown you, we're using hemostatic powders quite a lot. With other devices, I frequently had catheter clotting because the working channel was not dry enough. You don't have the possibility to have constant airflow before you administer the powder when you use hemospray or Endoclod, because they just are not designed to have that. There I have a frequent catheter clotting with next powder. I think if you pay attention to very few and simple to follow tips and tricks, you're good to go there.
Yes, don't be careful with aspiration.
During
the procedure.
Yeah, make sure that you have the, as with every device you use, whether it's APC or endoscopic powder, make sure that you have 2 centimeters, the catheter 2 centimeters out of your scope, if possible, if the anatomical size allows, and those kind of things.
Mm-hmm. Thank you. We have many questions about the comparison between the next powder and the other topical powder.
Yep.
What is your opinion? What is the advantage of the next powder?
So in all those cases we didn't have any advent, although we record them quite vigorously. And as we're also doing a clinical observational study on Next Powder. We don't have, in terms of efficacy, direct comparisons between Next Powder, Hemospray, and Endoclod. We can only transfer data from one study to another. In the past, we've directly compared Endoclod and Hemospray. They were equally effective. I think for the moment, we have to kind of remind us of the technical properties of the one or other powder to decide what we use, because we don't have comparative data on the effectiveness. Then I think it's your own preference what you want to use. I personally, not only because we're talking on this during this webinar, I preferentially use Next Powder. And also on our emergency card, we now have Next Powder. Initially, we had another device, but since Next Powder was available to us January this year, we changed it because we have low pressure application and maintaining endoscopic view. This is really important. When you use Hemospray and you start spraying, the procedure is done within 2 seconds because you don't see anything. You have to pull up the scope, and even if you do a second look directly, then with the same scope, you only see a grayish powder covered through the mucosa. So it's a very high scattering, and you don't have any possibilities to actually check your bleeding site, because it's if you use it in the stomach, the whole stomach is covered. I think everyone who uses or has used Hemospray would say the same. And this is, to me, the major difference between
the good visualization of the, the field of view, of course. And perhaps we have time to one more question, and after we will have one more question after perhaps my presentation.
Yeah.
We will
so
answer.
Yeah. So then we proceed, and now it's me again introducing Gabriel Rahmi. As I said, he's really has a worldwide recognition for his advanced endoscopic resection. So Gabriel, we are very honored having you here talking about Next Powder for bleeding prevention.
Thank you very much. I am very happy to be with you tonight, and thank you very much, Professor Rath. My topic is on bleeding prevention and delayed bleeding prevention after tumor resection. Endoscopic tumor resection allows, as you know, integrity and functional organ preservation. EMR and ESD are the most commonly used technique for tumor resection, and one of the most frequent risks is bleeding, and of course, immediate bleeding, which is not a complication now, I think, but delayed bleeding is a challenging complication. What is the definition of the delayed bleeding? ESGE defined the delayed bleeding as a bleeding occurring after the procedure up to 30 days post-polypectomy, and with the need of emergency rehospitalization or reintervention as repeat endoscopy, angiography, or a surgery. And as you can see on the table on the right part of the slide, the delayed bleeding rate is quite high for the duodenal tumor resection, 5 to 15%, and the stomach resection, 1 to 10%, but also for the colon and the esophagus. We will discuss about first colorectal cases and delayed bleeding. As you know, the main indication for colonoscopy is the colorectal cancer screening, and adenoma resection is associated with a significant decrease in colorectal cancer incidence and mortality. Resection, the main complication are perforation, of course, but the most frequent is the bleeding. We can say that in the literature, the bleeding rate, delayed bleeding rate after piecemeal EMR is it's higher than after ESD. What are the risk factors for delayed bleeding? First, factors related to the patient. Age, more than 75 years old. ASA score more than 3, comorbidities, and of course, antiplatelet and anticoagulants use. Factors related to the polyp is a large polyp, more than 40 millimeters in the literature, proximal location, the right colon, for example, and in some published studies, the number of the submucosal vessel. What about the technique? If you cannot succeed to completely close the scar after EMR or ESD, and a second factor, which is a complex EMR and the position, this is a factor for delayed bleeding. How can we prevent delayed bleeding? First, what about epinephrine solution injection? You know that there is a temporary effect. What about thermical methods, APC, hot forceps, heater probe? For example, in the duodenum, there is a risk of post-polypectomy syndrome, and the same for the right colon, for example. And what about mechanical methods? Through the scope clips, we have many studies in the literature with the evaluation of this method. We will see this method and over the scope clips, but it remains quite difficult to close large scar. I think this is the main limitation. I would like just to discuss this first published study in gastroenterology in 2019. It's about more than 900 patients from different countries. It was a randomized control trial, and for patients treated by EMR for polyps more than 20 millimeter. As you can see on the figure on the right, there is a significant difference with the advantage in the clips group for proximal polyps and not all polyps. There is a difference in the proximal polyps in terms of delayed bleeding, as you see, 3.3% versus 9.6%. But what is interesting in this study is that the failure rate to use a clip is 14% and incomplete closure is 18%. Then in 1/3, more or less, of the cases, we cannot close completely the scar. This is a main limitation. This is another published study in the same journal in the same year, and it was a US study with the inclusion of polyps more than 10 millimeter treated by EMR. There was no difference between hemoclip group and no hemoclip group. What are the recommendations from the ESGE? You can read this recommendation. And ESGE suggests that mechanical prophylaxis, use of clip, could be discussed in certain high-risk cases after resection, based then on the patient's risk factor. We have many groups, international groups, working on this, on the identification of this risk factor. I think that this is a very interesting score, Australian and Spanish score, to predict the delayed bleeding. There is 4 indicators, 4 factors. First, ASA3-4 or major comorbidities, lesion size more than 40 millimeter, proximal polyp, and of course, use of antiplatelets, of anticoagulants. The sum of the points could predict the risk of bleeding. If you have a score more than 7, the risk of delayed bleeding is high, more or less 15%. In these cases, we have to think about a technique to prevent an endoscopic technique to prevent delayed bleeding. We need for innovative technique. And as the Professor Rath told us, Next powder is a very promising technique because it's first easy to use. And this is a highly adhesive properties thanks to gelation. We saw very well in the previous presentation, not so chlorine and scattering, and we have a very good visualization. This is the first case. It's about a woman with a lateral spreading tumor, 56 years old, and we decided to resect this tumor with the technique of endoscopic submucosal dissection. You can see here the location. This is a rectal tumor, and we use the Eluxeo system with the virtual chromoendoscopy with BLI and with magnification. We can see that in this tumor, there is some areas with irregular vessels and irregular glands that we can predict here neoplasia. We use here under immersion with water pump. We can predict a neoplasia. That's why we choose the endoscopic submucosal dissection. First step, we make an injection using an injection needle. And to prevent bleeding, we use soft coagulation using the tip of the knife, which is here the flush knife 1.5 BTS. We grasp the vessel from the left, from the right, and we then use the swift coagulation to make the dissection. And after the final cut, we have a large scar. Then it's quite difficult to close this scar using clips, even if we have some good results in terms of prevention of delayed bleeding in the literature. That's why we choose in this case the next powder application. You can see here the spray body, and we use a catheter passing through the operating channel of the endoscope. We can see here that it's quite precise. We can target the scar, and we use the powder. This is a blue color, I think a very nice color. We can see the gelation, and we use some water. We can wash the scar before the powder application, and we can see here some vessel under the gel. This is a second case, a colon case. You can see that this is a large colorectal tumor, extended tumor. We use the same virtual chromoendoscopy, and we can see that the glands are very irregular and the vessels are regular. The classification we can use, for example, in this case, is SANO 2, for example, and we predict adenoma. We choose in this case to perform a piecemeal EMR after injection. We use this snare, which is the standard snare. During the piecemeal resection, we often have bleeding, but it's immediate bleeding. We can coagulate this bleeding using the tip of the snare. But after resecting all the lesion, and after washing very well the scar, you can see that once again, it's quite difficult to close the scar using clips. That's why we choose this next powder application. We use a catheter passing through the endoscope. Because it's a colonoscope, because it's a colonic cases, but the previous case, it was a gastroscope in the rectal location, because I performed ESD using gastroscope, and there was no problem to pass the catheter through the gastroscope. It was colorectal cases. Now, what about gastric and duodenal cases? You know that gastric cases, gastric resection, one of the challenge is the delayed bleeding. Predictive factors are anticoagulant comorbidities and the location in the antrum. Of course, a large scar, and we don't have, for the large scar, very satisfactory therapy to prevent delayed bleeding. That's why even we can use hydrogel, hemostatic powder, sheets sometimes, and fibrin glue. I think we need innovative techniques, and it's the same for the duodenal resection. If you, because of the wall of the duodenum, which is thin, if you make coagulation, too much coagulation, you will have the risk of delayed perforation. If you use clips, we have limitations because of the risk of perforation. Do the clip application. And of course, if you have a very large scar, such as in the colon, it was not possible to close the scar. And thanks to the recommendation of the ESGE, we know that emerging techniques should be considered on a case-by-case basis. That's why in this case of huge, large duodenal adenoma, we use the next powder after a piecemeal EMR. We use the NBI chromoendoscopy, and after resection using a standard snare. We have this very huge scar, and we can apply it very easily. I told you that it's quite easy to use the next powder, and after application, you can see that even if it's quite circumferential, we have a good gelation. We use the washing pump. You can see on the left the water, which promoting the gelation. In conclusion, advanced resection techniques are rapidly evolving, allowing larger and larger tumor resection. Delayed bleeding remains a major challenge, and usual techniques remain unsatisfactory to prevent delayed bleeding in high-risk patients. That's why I think that next powder represents a promising new approach for bleeding prevention. We need more data. That's why we plan to conduct a study, a randomized controlled trial, the name is Next Bleed Study, to evaluate the next powder application efficacy after colorectal EMR in patients with high risk of delayed bleeding. Thank you very much for your listening.
Wow, Gabriel, I think this is really, we were all mesmerized by the beautiful images and videos that you've just shown to us. There are also a couple of questions on your presentation. And I think we have enough time to cover the majority of them. So one question, when you use, from the audience, when you use next powder to cover your resection sites, the question is, do you need to dry the EMR or ESD site, or do you actually flush it before you apply the powder? What is your approach here?
In my experience, after removing all the specimens, I always wash the scar. And I wanted to say that before applying the powder, I think it's very important to coagulate the visible vessels you can see onto the scar. I use the tip, but gently with the tip of the snare. I coagulate all the vessels. If I used a hot forceps or coaguloscope, for example, I can also coagulate all the vessels visible on the scar. And after that, I apply the next powder. But sometimes, you know, because of the size of the scar, sometimes there is. It was the first question about active bleeding. Sometimes there is no sufficient gelation, then to promote the gelation, you just have to use some water. And because I use a washing pump, it's quite easy just to use the water.
Yeah. Okay. Thank you very much. And a good amount of questions also comparing to other devices. We've had that during the bleeding talk also. Here, another substance is frequently referred to, Purastat, because we learned that in the past we can also use Purastat, not a hemostatic powder, but a gel to cover resection sites. Do you see any advantages, disadvantages, one over the other, when to use this or that? Can you comment on that?
Yes, it's a very good question. I am not sure I have the answer, but we have no sufficient data to answer. Of course, one of the main advantage of the next powder, I think, is that it's very adhesive. Mm-hmm. Adhesive, it's a gelation. The gel, you can put the gel, but the washout, for example, in the stomach, the esophagus, it's very fast. But I don't have any. It's my opinion. Yes, my feeling. It's my feeling. You know. Then I think that next powder, it's like adhesive gel. The factor, the adhesivity, I think it's a main advantage. But I don't have any data published comparing the efficacy of Purastat versus next powder, but it's of course a very good question.
Yeah, I fully agree. There's no data on the efficacy post-resection bleeding. However, maybe it's something that we've already discussed before. The mode of action or the applicability might be different. When I use Purastat, I sometimes have a hard time with gravity. If I have the lesion in a gravity-dependent position, it can happen that the gel, in this case Purastat, drops off. Next powder is kind of sprayed on the mucosa, which is a different application. But we don't know about efficacy, but mode of action, applicability is different between those two agents. So to answer those questions on comparison, Purastat, this might be one of the answers. That also depends on your preference and where the position of your resection site is. And if you have a hard time putting that into an anti-gravity position, Purastat can easily go off, as you also said.
Yes, I totally agree, and we know that the next powder, the powder remains onto the scar and 3 days after, and probably this is interesting information also.
Yeah, let me just look here. There's one question: how much powder do you use? Do you have, or what can you say there? Do you need a whole vial? A whole vial contains 3 grams of powder. Is that enough for your resection sites in the majority of cases? Do you need 2 vials, or is 1 plenty? What do you think?
Yes, I use 1 and 1 plenty.
Okay.
Yes. Not 2, and you remember that it was a large scar, quite large scar, and 1 vial was enough. It's 3 grams, and I use, of course, I try to cover all the scar. If I have more and more powder, I use all the powder because why not?
Because you have it, yeah, that's right.
Yes, because I have it, and
yeah. If I can add that, we're using that for 10 months now, since it was launched or approved here in Western Europe, including Germany, in January, or a little bit earlier. We're using it since January. I never had a patient where I needed more than 1 vial, even for large lesions, as you said, Gabriel. If you look at the studies that I've shown you, the initial studies, the study on bleeding in 56 patients, out of those 56 patients, there were a small number of patients where the authors at that time used 2 vials. So at this stage, I think it's fair enough to say one vial, 3 grams of powder is plenty, and you can cover even circumferential bleeding sites or resection sites.
And Timo, do you use the next powder for the lower GI bleeding, or do you have an?
Yeah.
Of course, you told us about radiitis, but
yeah, we had another case just recently that was bleeding due to underlying indeterminate colitis. So not Crohn's, not ulcerative colitis, but those are patients that that are in between, indeterminate, and she had quite heavy bleeding due to generally vulnerable mucosa. So again, fragile tissue, you don't want to stick a needle in there, clips don't hold, so there we used it also. For resection site, I used it, and those cases of radiation proctitis that I've shown you. Yeah, there's this also might also be one of the difference, because it's approved, at least in Western Europe, for use in the lower GI tract, which is not for every hemostatic powder out there the case. So no.
Okay, and about the lower GI and after upper GI, what about varicose bleeding?
Oh yeah, I've never used it in varicose disease.
Yeah.
Well, because if you have a 1A varicose bleeding, we know that we like the rubber bands.
Yes, yeah.
So we have to wait for further data there.
Yes. The company does not recommend, I think, to use it for the moment in the varicose bleeding.
Yeah, but you're making a good point, because usage in the esophagus is another question here. It can be used in the esophagus. Think about bleeding reflux disease. This is one of the cases where you can use it, and I've actually done that in the past. Yeah, there are a good number of questions that are very hard to answer. It's about cost effectiveness, about from next powder compared to other hemostatic devices, other powders, and also other clips. Here, short answer, I think, if I can answer that, it certainly depends on the region where you're located, and also the hospital you're working in, what kind of conditions you get when you purchase endoscopic powder. So this is a question, unfortunately, that would be very tough to answer, because there's so much regional differences. Another, and maybe this is the last question to conclude, have you ever used it in the duodenum after ampulectomy?
I have no experience. I don't know if you, Timo, you always used it.
Nope.
No, I think that we know that other powder, we have data in the literature, it's quite safe. But I think that we need more and more data in this specific case. For the moment, we need more and more data just to answer. But we know that in the literature, with all other powder, it works. It works. It's safe. It's safe and it's safe.
Yeah, I agree. I think we have covered the majority of questions. So if you want to conclude, then.
Yes. Oh, thank you. Thank you very much, Timo, Professor Rath. Thank you. Of course, I will be. I was very happy to be here with you. I don't know your city. You are in the University Hospital Erlangen.
Yeah.
Yes. Famous endoscopist, and congratulations for the presentation. It was a great presentation about the topic of tonight, about active bleeding and prevention of delayed bleeding. It's a frequent situation. It's a challenging situation for endoscopists. And I think that next powder is a new alternative, a new technology, and it's easy to use, as we can see now in our experiences. But of course, we have to promote clinical trial. We have to promote evaluation to have more and more data. then now we can conclude and say thank you very much, everybody. Thank you to the audience. You know that ESGE Days 2022 will be in Prague in April 28 and 30. Be careful, abstract deadline 7th of December. And we can move on, and you know there is good news, new benefits for ESG members, two very nice tools. The first is my ESG tutor, and there is a very nice application for checking the quality in your endoscopic room. Then please go to the ESG website. And the next webinar, I can say that it will be on December, in 1 week, the 8th of December. And it's the best of the live endoscopy of the ESG Days 2021. Please come and attend. And of course, I will thank very much, I think that Timo also, we thank very much Medtronic for the invitation, of course, the ESG governing board, and the excellent webinar team, David Inker and Gabriela, or Gabi Varga. Thank you very much for all the team.
All right.
Timo.
Thank you very much, everyone. Have a good evening.
Have a good evening. Thank you very much, everybody.